welcome back to another episode of Oncology for the Inquisitive Mind, a very, very special episode. I am joined, as always, by my turtleneck rocking co-host, Josh Hurwitz, looking very dapper in the Melbourne winter. Josh, are you feeling warm enough to proceed?
Almost, Michael. I was going to wear my woolly coat and I decided on YouTube it might not look that nice.
Yeah, I think that puts us above some other podcasts I can think of. But anyway, it's not about us today, as it very rarely is. We have a very special guest and one of my oldest and dearest friends, Dr. Kerry Jewell, joining us today. Kerry was born in Wodonga, for those of you who don't know, which is in northeast Victoria, and she is a veteran of the state's public health system. She's a doctor who has always cared for her fellow clinicians, going back as far as chairing a professionalism committee aiming to smooth some of medicine's, how do I put this, diplomatically, rougher edges through engagement and education. After flirting with training as a geriatrician, she instead pivoted to nuclear medicine, completing her training while playing a pivotal role in myriad practice-changing studies, including Violet and Alphabet. But Kerry's talents don't stop there. I told you this was going to be a long one. Eloquent and gut-bustingly funny, and too busy to pursue a career as a stand-up comic, it was perhaps natural that she gravitated to writing. After publishing short fiction in local and international publications, including the Saturday Paper, Ireland, and the Bath Short Story Award Anthology, she was shortlisted for her debut in 2020 for the Rochelle Prize for Emerging Writers. That debut novel became A Little Unwell, which was published by Hachette in May 2026 and is already in its second run of print. If you haven't read it for whatever reason, stop the episode straight away. Go out and buy it. I've read it and I'm not biased in any way when I say it is brilliant. Over the last 2 years, Kerry has been fighting a battle that goes beyond temperamental surgeons and hospital administrators. Diagnosed with breast cancer in 2024, she completed her treatment last year before receiving news of a relapse less than a month ago. However, showcasing her Energizer Bunny personality and the fact that she has never entirely shed the bogan, she has approached this latest challenge with the same straightforward bull to matador's bum energy. Having only commenced systemic therapy yesterday, and presumably buoyed by the aforementioned personality and energy, but also a significant dexamethasone wave, Kerry has given up some of her valuable time to join us on our pokey little podcast to share her humour, eloquence, and wisdom. Kerry, welcome.
Well, am I welcome, Michael? I've taken several notes from that introduction. I'm going to have to rebut immediately. I didn't think we were choosing violence this early in the morning. Yeah. All right. 1, is that the first time you have introduced a guest with the moniker of bogan?
It's the first time we've had one.
Right. And is it because I'm a woman? Let's just ask that straight up. Would you have?
Kerry is definitely choosing violence.
Yeah, right. Okay. Well, we will have to circle back. We'll have to circle back to that. 2, yes, I have had a little juice yesterday, but I can happily report that I am not on dexamethasone right now. This is just who I am. This is not particularly steroid addled for me, I don't think. Yeah, wow, what an introduction. Thank you so much, Michael. This is clearly why you are one of my oldest and dearest friends. Anyway, let's see how much damage I can do in the next little while and see if this program has to continue as a solo project for Josh. We'll see.
Yes, I think we're headed that way, but let's be honest, Josh is always the brains and the beauty behind this project. Kerry, you first wanted to talk about, amongst your many points of wisdom, about your chosen profession of nuclear medicine. And you have started here with the very helpful, I think, title of How to Get More Out of Our FDG Pet Requests, which I will speak for, I think, the oncology profession at large is something that we're pretty bad at.
Yeah, look, as you have mentioned at the top of this podcast, I am currently dealing with a diagnosis of metastatic triple-negative breast cancer. But I really thought for your listeners that there was not a lot of point dwelling on, no point crying over spilt memories, and that we should still make this educational. So yeah, I have some unique insight as a nuclear medicine physician working here in Melbourne. I did my first 2 years of nuc med training at Austin Health after a long period of BPT. And then I did 2 years as a fellow at Peter Mac, and then worked as consultant at Peter Mac for 2 years after that, and have also been working at Cabrini Malvern at IMED there. So lots of varied experience, and have seen many a pet request in my time, and have had to call some of your listeners probably about many a pet request in my time. So looking forward to shedding some light on how we can get the most out of each other and do better for our patients. But to be honest, there's really not that many notes. I think 10 pages should cover it. Is that going to be, have we got enough time for that?
We have as much time as you want, Kerry. We can turn this into like a week-long marathon listen / watch.
I mean, this is just a therapy session, actually. Just go through all the most soul-wrenching cases that have just kept me up at night, being like, why didn't they just tell me they were on immunotherapy? Anyway.
Well, yes, speaking of immunotherapy, that's your first point.
That's probably a good place to start. Yeah, no, look, I'm probably sounding more chaotic than I need to. Again, I will highlight and say that the majority of FDG PET requests that we get are very appropriate and very helpful, particularly if they're not handwritten. Some things that could help us all out and maybe save some phone calls, which I know how busy medical oncologists are, or all oncology disciplines are. So that's where this comes from. A place of love. I want to save you time. Help me help you. Look, one of the things that is really helpful to know is if a patient is on immunotherapy, often we can tell from the tumour line that or where they're up to with their treatment, that they probably are on an immunotherapy. But when out of nowhere the pituitary gland or the thyroid or the colon lights up, it's really helpful for us to know immediately whether we're suspecting that's more likely to be an immune-related side effect, or if we should be thinking more broadly about inflammatory infectious causes as well. And it's really helpful, particularly if you've been seeing a patient for melanoma restaging and we have a squillion prior scans from them, if suddenly something new has lit up, if they've had a change in therapy, but they've just had their usual 6-month or 12-month or request for screening that hasn't been updated, then yes, sometimes it's helpful if that information could be sent through. I know not always achievable. Everyone is very busy, but again, might save a phone call. Something that I like to do with my reports is often at the top when I'm giving clinical information, I'll also state what date the referral was written. Now, that's a little bit of a unique thing that's not a standard practice, and you probably won't see it on many other reporters except for my reports. But I think it gives good context to the clinical history that I'm writing out. And generally what I do, earlier in my career, I tried to summarise a little bit. I think that was my BPT brain active. But generally now, and I think this is what a lot of nuc med specialists would do, they will write verbatim what is in the request, because we don't want to necessarily think that we know better than the referrer or make assumptions that aren't there. One thing I will do is spell out abbreviations so that if it is the right abbreviation, we're all on the same page. But if I have interpreted the abbreviation wrong, then you'll see that in the clinical history. And if that's going to be clinically relevant, that's something that can be corrected. So my approach to reports is trying to put in as much information as possible without turning it into war and peace, so that it saves you time at the clinical end. I think the first point around immunotherapy, really, really helpful, particularly around colitis, I think. It's an immune-related complication we don't want to miss, particularly at the higher grades. But there are a lot of things that are metabolically active in the colon, and the patterns aren't necessarily easy to delineate from one another. It can be very non-specific. I'm sure you all hate when you see the term non-specific or poorly specific on our reports, but it's the truth. We are not pathologists. We don't have a tissue for what we're trying to describe on imaging. So we are trying to be as helpful as we possibly can when we say that it's non-specific. That clues you in that we're thinking a broad differential. But yes, particularly for the colon. So I think more commonly, the things that we see that turn a colon black, metformin in particular, can do it. And so it's really helpful to know if your patient has a history of diabetes. most, if not all, of the PET centres around Australia and New Zealand will have technologists collecting a patient worksheet before we do the study. So we do get some information from that. And diabetic status is one of the things that's right up the top. So usually we'll know, although not every patient is aware of their medications list. So if you know that they're on metformin, flagging that with us on our referral is very helpful. We also sometimes talk about what we call like a loose, rough umbrella term for exaggerated physiological activity or physiologic activity in the bowel. And that's a bit of a catch-all as well. We know that there's lots of things that affect motility in the bowel and can cause inflammation. And it's really just trying to assess whether that is something that is clinically significant enough to call through if it's something serious. Again, not all patients will tell us if they're having significant GIT symptoms. It's something that we will probably probe for in the nuke med department if we see something that looks a little bit funky. But again, if you've already flagged with us that it's immunotherapy, that helps us take a bit more of a targeted history and to help you work out whether it's something that needs to be phoned through and acted upon.
It's a good baseline to start. As you said in your note, where was it? It was, you said something about being hot. Where was that little note? What's running hot, baby? I quite enjoyed that.
The quote was, we can tell you what's running hot, baby, but not why it's running hot, unless we can, because sometimes we have our genius moments. But, nuke med folk are fairly humble, and so we try not to call it on you.
You get to hide behind the screen in some nuclear medicine. My next question is, you've talked about immunotherapy and, being told that you're on it. That's really good. And you've got other things which we haven't mentioned. So things like sarcoidosis and having a prior pleurodesis. And I was wondering, when you go and scan someone and someone's got sarcoid, which, how many scans do you get? Potential sarcoid, is this metastatic disease? Like, what's your approach for someone who is maybe an unknown diagnosis, or what's your approach with those sorts of patients?
Yeah, all right. Well, I'll tell you about a horror story from earlier in the year. I was doing a cardiac stress test, and we do a low-dose CT with those studies just to have a check, mainly to see if there's coronary artery calcification present, because that helps us with our risk stratification. But I had a younger patient who was having a cardiac stress test, and I was looking at the lung window for their low-dose CT, and suddenly there were bilateral solid lesions. And I was grieving for them. I'm like, oh my goodness, this is going to be metastatic lung mets. Probably not a primate. It looks like lung mets. I calibrated against another radiologist in the room, and they're like, yeah, probably lung mets. So I was grieving for this patient, and I had to work up to call the cardiologist to let them know. And so rang through. I'm like, oh, look, letting you know that the cardiac part, great, heart's working really well. However, I've just found these things in the patient's lungs, and I'm really sorry to have to pass on that news. And the reply was, oh yeah, I know they've got sarcoid. That's been there for ages. Don't worry about it. And I'm not joking. That was 20 minutes out of my day at least, probably a little bit more. Reviewing it in detail. The patient had already left the department, so I couldn't take any history, nor would I. It's a bit of a grey zone in nuke med, but we try not to alert patients to any potential sinister pathology while they're in the department, because I think everyone has slightly different takes on this, but my personal feeling is that's a bit disrespectful for the referring clinician, unless I've received specific advice from a referrer over the phone that they want something disclosed or managed in the moment because they can't. I find it disrespectful to, try to treat your patient for you, unless, as I said, there's some way I can be helpful. But it had taken a lot of time to try to gather up some information. I had tried to see if there was some previous imaging I could compare to, didn't have anything on file. And then just even trying to get through to the referring clinician to have this phone call was a little bit of a mission as well. So that's the kind of thing that if it had just been like a line on the referral, would have saved us all a bit of time. The other thing that sometimes sends me off is pleurodesis. Now, as I've progressed in my career, I'm a bit more clued in, but I can tell you as a nuke med registrar, when I'd see a hemi lung lit up with highly metabolically active lesions on FDG PET and suddenly feeling like, oh no, this patient's had this awful pleural-based recurrence. But then, and this was the advantage of being at hospitals with an integrated EMR, that I could go back and do a little bit of research myself, also time consuming and most new med specialists aren't necessarily going to have the time to do that in-depth research, but particularly as a trainee, trying to push myself to do better reports, get more information. Yeah, as soon as you've seen that they've had interval pleurodesis, like, that makes total sense. I will lower my heart rate. Also would have been great to mention on the referral slip. So that comes back to this idea if it's running hot, you're like, we're going to probably be operating at a higher rate of knots. But if it's running hot for a benign reason, it's really helpful for us to be clued into that.
I don't think you've ever lost your med-reg thoroughness, Kerry. You always got to...
Well, the point I missed out from my bio, Michael, that I am so disappointed in you with. I thought we'd done better, but I actually started BPT wanting to be an infectious diseases clinician, which probably makes a lot of my obsessive documentation make more sense. And that stems from the fact that I did a BMed-Sci in malaria vaccines over in England. And I thought I was going to come back and have this wonderful career, like curing all these amazing infectious diseases all over the place. But then I did a rotation in it as a resident and realized that it's mostly just fighting with orthopedic surgeons about antibiotics. And I was like, I can't do this for 50 years. I just can't. And then my next rotation was with a lovely geriatrician named Will Brown at Eastern Health, and he showed me the light. And then I should have probably stayed with Jerry's, but over COVID and while waiting to resit my clinical exam for BPT, I was offered a 1-year fellowship in dementia imaging, essentially, with the Nuc Med department at Austin Health, and literally was in that job 2 or 3 weeks. I was like, this is what it feels like when you find your calling. So that's my journey through internal medicine.
Well, I mean, yes, I wanted to do your entire journey, but then I suspect that you would not have much chance to talk, Kerry, because you have had an incredible journey up to this point.
Oh, well, thank you. But again, multi-episode arc. Like, we could have... No, I don't want to bore your listeners.
I think one interesting point that you have put here, Kerry, just to get this train back on the tracks, as it were, is
we're not on the tracks, Michael, please.
That's true. I don't know why I even thought it would start on the tracks, but you've mentioned how you avoid specifying what test to do next. This is something that I think we often see in other nuclear medicine physicians. They'll say, further characterization with an MRI, or, if you're looking at neuroendocrine pathology, a dotatate PET, or something. But you've said that you generally avoid specifying what test to do next. And I just wanted to get your thoughts on that.
The way I think about it, it depends on where I'm reporting. So if I'm in a highly specialist centre with referrers I work with quite commonly, who I know will be reviewing the report in a timely way, that's the situation where I'm less likely to give clinical advice in my conclusion, because I know the loop is going to be closed, it's safe. If I have referrals from St. Elsewhere, unknown referrers, or particularly this situation arises where you have specialty registrars that are on short rotations who are then going to be rotating out of the hospital, and the line of communication has a greater chance of being interrupted, that's probably where I'm more likely to write some advice in the conclusion, or even ring it through if I think it's serious enough. It is difficult because you want to strike that balance of being helpful and give a short, succinct conclusion. The way I approach the whole report is I give a lot of detail in the body of the report, but then I'm trying to write as small a conclusion as I can that you can briefly look at and understand exactly what's going on with the patient. The body of the report is more so that anyone reading it, particularly any future nuc med specialists as well, can visualize. So I aim to write a report that you can visualize exactly what is going on in the body. But the conclusion is so that you can have a very quick read and walk away and feel like you have a good understanding of where this patient is up to with their restaging or their initial study or whatever it is you're doing the PET scan for. In terms of recommending other tests, it can be really tricky. I'm very cognizant of the fact that patients have greater access to their clinical information now, which I think probably overall is a good thing. But I don't want to tie your hands as a referrer by recommending a test in my conclusion, particularly if it's a little bit atypical, and then a patient of yours reads it and feels like that they have to have that test, or that you are under treating them if you don't do that test. So Yeah, it can be difficult. I think probably the most common thing that I would recommend is what we would call an anatomic or structural CT. As I mentioned, the low-dose CT that we do with PET scanning does not have contrast and it does not give us much detail. And also many of us who've come from the physician's pathway, our CT anatomy is not as great as a specialist reporting radiologist. If we see something that doesn't look quite right, we will often calibrate against a radiologist in the same reporting room as us, but we don't necessarily have the ability to see everything because we're there for the functional part of the imaging. So sometimes I will recommend an anatomical structural CT is what we're calling it. And what I'm saying is there is something here that needs to be characterized in more detail than what our low-dose CT can provide, and it would be very reasonable for you to do that. But again, everyone is slightly different. I know that there are some of my colleagues who would commonly put tests in their conclusions to recommend, often more senior specialists who have far more knowledge than me, and it's all coming from a good place. And as I said, they know more than me, so they probably know exactly what they're doing. But as an earlier careers consultant, I'm just mindful that patients can read these reports, and I don't want to make your jobs harder by listing wacky tests in the conclusion, and then you're sitting there reading it being like, God, who is she getting kickbacks from, honestly?
So if we get a reply from you, Kerry, that requests that we do, I don't know, a toe nuclear medicine scan of the big toe, then we'll know that there's a real reason for it.
If I recommend you something very specific, then I'm feeling hot. Like I'm feeling very confident that we're on to something.
You're having one of your patented genius moments.
Yeah, I've got like the little equations, the little ghostly figures floating in front of me, all coming together.
I guess the other understated part, and probably I would imagine the slightly more frustrating part from your perspective, certainly from our perspective, is working within the frameworks of the public healthcare system. Now, this is something that is changing in terms of what we can and cannot access. It used to be, I think, and correct me if I'm wrong, Kerry, that there used to be a hard limit on just normal FDG PETs when the technology was pretty new. Obviously, with PSMA PETs, the accessibility is changing and the usefulness and the implications of it are changing. So you've got some notes here that you wanted to talk about some of the updates to Medicare codes, which I know trainees and early career oncologists would find really helpful.
Yeah. Look, I'll give a shout out to the Australasian Association of Nuclear Medicine Specialists at this point, of which I am a fellow and fellow member. This is our professional organisation. Again, we are a small specialty. There's only about 500 of us spread between Australia and New Zealand. And the advocacy work that is being done from that organisation is happening at a really, really high level. So shout out to recent presidents Zeting Lee from Austin Health, Paul Beach from Alfred, and Elizabeth Klingon from the Wollongong area, who is our current president. There has been a really strong through line over the last few years lobbying for better access, because we know our scans, particularly PETs, can be a limiting factor for patients who can't pay out of pocket for them. They are good tests that we want people to have access to, particularly coming from areas of disadvantage, those patients that are coming in from the country. We want our patients, our shared patient pool, to have access on Medicare for these tests, because they can really change the course of someone's treatment journey. And I can speak from personal experience to that, having had a number of PET scans in my time that have been really informative in terms of how we've structured my care. And in the past, I wouldn't necessarily have had access to that, and it could have been made a big difference. So I can even say that from a personal level. But yeah, there's been a lot that has come on online in the last couple of years. It's been really helpful. I've got this little laminated sheet here that I keep with me at the table side. This is from my primary employer, IMED at Cabrini Malvern. And I think I'll come back to the PSMA PET in a moment, but I think one of the most helpful things that's come online in recent years is this new category around FDG avid cancers for both staging and restaging. So this covers all of the rare cancers, but in practice, the way that we can use this now is that anything that we as the multidisciplinary team think is going to be suitably FDG avid, we can put it under Medicare now, and that's fantastic, because if something is highly metabolically active, we can see it on FDG PET and characterise it for you. That's great for the patient. So there's really not a lot in the oncologic space now that we can't get under Medicare, which is really helpful. And that's not to seem shady, like, oh yeah, we're getting it
under the radar, yeah.
These are indications that should have been there for much longer than what they have been. And we could dwell on that negative past, but we won't. Let's just be positive about how much progress has been made and what more there is to come. So FDG PET's running really well. I think for the non-oncologic indications, there's more to do on inflammatory and infectious indications, things like vasculitis in particular. But I've got some wonderful colleagues I'm thinking of some dual-trained rheumatologists in particular who are doing some great work in this space. So I expect that will come on board too in the next short while. And again, that will be really helpful for patients. So FDG, the workhorse of our PET centre, that's pretty well catered for. And just in case there are any writers who have strayed onto this podcast, because as we'll get on and talk about my book, I am doing a lot of writing-based podcasts at the moment. When I'm talking about the radio tracer before a PET scan is positron emission tomography. So this is the functional imaging that we're doing to look at the body. The little abbreviation at the start is what type of tracer that we're using. So FDG, I'm not going to say that because I've learnt that for my exams and I've dropped it again. It's a very big, long chemical name. We don't even need to do it. Don't test me like that, Michael. Stop.
I really want to, though.
I want to time out here and say that you know that I am not great at pronouncing medical words. I looked at Farrah Hall at Monash for my first 2 years of training and like my non-clinical years for medical school. And I'll never forget the day that my friends busted me sitting on the edge of the bed repeating peptidoglycan over and over because I just couldn't say it. And that was a moment. I think the other thing that you will recall, Michael, is when we were studying for physician's exams and there was a certain cholesterol drug that I was struggling with.
I won't mention it, but I will put it out there that there was a certain cholesterol medication that came off with a certain Caribbean flair.
I'll say it. I'd only ever seen it read. So Isotimbi sounded like the correct pronunciation to me. Pronunciation.
Yep.
Yeah.
Yep.
This is why I'm a writer. I am a speaker too, but yeah, I just have to practice some of those harder words.
Ezetimibe is just not as fun to say, to be honest. I still say Ezetimbi based on that. But yes,
I can't. But hey, we got through our exams, so we got
through our exams, and no one really cares, and we're not going to prescribe that medication ever again.
But anyway, so PET is the workhorse. It's looking at glucose metabolism in the body. As you know, cancer uses a lot of glucose. It's very good in that way, so that's how we can see it. But we have got new radio tracers that are coming online. So one of them is dotatate or gatate for neuroendocrine tumours. That is a space that advocacy work is being done right now because there are quite a few of the neuroendocrine tumours that are not well picked up by Medicare at the moment. Again, it's really hard when it's a rarer cancer, although neuroendocrine as a whole category is not as rare as you might think. But yeah, we do need to do more there so that more patients can get access under Medicare to those scans. But I'm really pleased to report in the PSMA PET space for prostate cancer, we have had a bit of a breakthrough there. So at the moment, the funding, and I'll just double check my sheet so I'm telling you the right thing. At the moment, there's a maximum of 1 per lifetime for prostate cancer initial staging, and then a maximum of 2 per lifetime for restaging. And there's a particular caveat here about it not being able to be used for surveillance, which is really tough because the phenotype of prostate cancer, particularly in that metastatic space, is ever changing, and we need to be able to characterize it more frequently with the whole wealth of different modalities now available to treat in that space. We need to be able to keep characterizing so when it shifts, we know that we're doing the right thing. So I'm really pleased to announce I'm not announcing it.
Something that you have specifically achieved, I am pleased to announce.
No, I did not achieve this, but I'm happy that it has been achieved for our patients, let me say that. But I can confirm maybe that as of May.
Confirm is a good way.
This is a recent announcement in May. From the 1st of November this year, MBS item 61564, which is the restaging PSMA PET, has now been amended to give eligibility to patients access for yearly scans, which is a great step.
Which is really good. And I know that you and I will be coming at this from different angles, but arriving, I guess, at the same conclusion, is that if places adhere to the PBS, and that's something that we'll gloss over, But then we would be ordering what used to be called standard restaging with a CT and nuclear medicine whole body bone scan, which then would, from your perspective, potentially have to be compared to a PET. And we know that those are not interchangeable. The PSMA PETs are usually, and please correct me if I'm wrong, much more sensitive for most things, but there are certain things, particularly if you do a CT and only a low-dose CT with the PSMA, as you've said, sort of anatomical associations, that a PET scan does not pick up as well as conventional imaging, and then you have to try and come to a conclusion for that.
Yeah, look, I've done a lot of work on clinical trials focused around prostate cancer, particularly in my time at Peter Mac, and the serial bone scans are really, really helpful in that context for monitoring bony lesions, and when they're paired with an anatomic CT for the rest, very helpful. But as we know, bone scans have their place, but if they are being done infrequently, particularly if there's nothing previous to compare to, they can be a bit tricky to interpret. There are a lot of benign bony conditions that show up as hot. Really difficult to know, particularly in the prostate cancer age groups, whether something is a traumatic fracture or if it's really pathological or something else. People who've never had a bone scan and then they have these really hot lesions, and then you have to do a bit of work to understand, is it really cancer or is that massive hemipelvis osteoblastic activity actually Paget's disease? I have seen that. The PSMA PET can be really helpful in that case, particularly for characterising nodal disease, particularly for characterising new visceral metastases, which obviously change the clinical course of things. So yeah, it's a bit of a balance, and there is a time and place for each of those studies, but the PSMA PET can be really helpful, and we're only getting better at it. So the accuracy of our cameras is improving, a whole lot of technical parameters for how our technologists prepare and execute a PSMA PET. They're all improving. And a little shout out to the technologists. So a technologist is to nuke med what a radiographer is to radiology. Please don't call them technicians. They are not technicians. They are highly qualified technologists, and they really, really are just, I cannot be glowing enough about the technologists I've worked with in my lifetime, because they have saved my butt on a number of occasions. So, the technologists, what they're doing with our patients for PSMA PET, it's all becoming more nuanced and more helpful. Lots of things to investigate from here, but I think we can only go up.
Yeah. You've told me, and I've met a number of your technologist friends, and they really do seem to be the glue that keeps the whole unit together.
Very good people. Highly rate them. They should be in charge of everything, actually. I actually think if we promoted more technologists into some of our political spaces, that things would just happen far more efficiently. They're a very certain type of person, and they get things done.
Well, then that can be your next project, Kerry. I think, though, that we should address the 500-pound elephant in the room, which is the quote-unquote journey that you have been on with your own breast cancer, and I guess that you have a very, very a unique perspective. I almost said very unique, which is the tautology, but anyway. And Kerry is nodding sagely. That you have not only the medical background and the patient perspective, which is something that is already rare, but you work in a specialty that is so intimately familiar with a lot of the mechanisms and the the regular routine, shall we say, of cancer patients. And then unfortunately you become one. I mean, I was there, I remember it, but it was a hell of a gear shift for you both times it happens, and you've got a lot of experience and unique perspective to provide.
Thank you. You're probably overselling me. I'm not sure how helpful I can actually be, but look, I have yes, it's true. I have this experience as a doctor who's worked in cancer medicine, now as a patient, and also, unfortunately, as a carer. My own mother had breast cancer and unfortunately died in 2017. So I have the full spectrum of experience. The full gamut. Like Pokemon, I have collected them all. It's not something you really want to do here, if we're honest. So if you can avoid that, please do. I hope you can avoid that. But yeah, look, I think now that it's metastatic, my approach is a little bit different to how it was back in August 2024 when I got my locally advanced diagnosis. At the time, I was doing an NHMRC funded scholarship funded PhD on lutetium therapy in prostate cancer and wanting to focus on how we can better deliver that to rural and regional patients. So that was my real passion at the time of the diagnosis, working on totally different tumour stream. I was also working clinically as well and had a lot going on. And I didn't really stop. So particularly for the first 6 months of treatment while I was having my neoadjuvant before surgery, I just kept working. And it was really helpful. One, I felt like I obviously had to peel back and there were things I couldn't do clinically because immunocompromise, direct patient-facing care, things like being in our therapy clinic and doing face-to-face cardiac tests I could no longer probably safely perform and probably wouldn't have wanted that for my patients either. I can only imagine what it would have felt like coming in for a cardiac stress test and having a bald, steroid-jacked clinician coming at you and being like, go harder on the treadmill.
I think some patients would have really appreciated that and they would have gotten better results.
Yeah, maybe some of them. For some of the others, there probably would have been complaints. So I self-limited what I thought was appropriate and on the clinical side of things, yes, was safe and was only doing what I could practically do. But I actually think it was really important because staying mentally engaged, still feeling like I was contributing, was really good for my overall experience of neoadjuvant therapy. And I kind of did my own little private PET fellowship. So rather than doing cardiacs and gen nukes, I was really doing a lot of PET. I excluded myself from reporting PET breast, not necessarily because I thought it would be overly triggering, but more I didn't want to be accused of bias of over or undercalling cases for my patient peer group. So I didn't report breast PET over that time. But it was really good. It was really good. Unfortunately, after my surgery and radiotherapy, while I was still willing, how to politely say this? I think sometimes people underestimate me, and I'm not sure if that's because male clinicians label me as a bogan. I'm not sure how helpful that is, Michael Fernando. No, look, I think
there's going to be a lot of chatter once we stop recording about that. I can guarantee it.
Oh yes, so much to do from here. We've got whole education modules that we're going to be putting you through, Michael Fernando. You are going to come out the most stunning ally of feminists that the world has ever known.
Feminism's not my issue, Kerry.
Yeah, it's just like the worst kind of little brother is just ragging on me all the time. I understand that. I do understand that. Look, I need it. I need you to keep me humble.
Well, you've already taken the credit for announcing the PSMA PET funding, so someone's got to bring you down one or two levels.
What I'll say, if I was a male clinician saying that, like I've got this game-changing announcement for you, no one would bat an eyelid, Michael.
That's very true.
I have a professor in front of my name, which I do not.
You should. What's the harm at this point?
What I will say is that I feel like over the course of my career, because I'm not someone that is particularly good for tooting my own horn unless we're in this like life-limited scenario that I find myself in now, in which case, sky's the limit. All of that bottle-up arrogance, it's just going to come pouring out. But I would say prior to this point, I am not someone that has been particularly good at promoting myself. But in the background, I'm like, I was going to say like a duck, like I seem very calm on the surface, but there's a lot of paddling going on. But I even want to say I'm more like an iceberg, like you see the tip, but there is a lot going on under the surface. I don't know if those analogies are helpful, but they're fun.
You're the writer, Kerry.
Yeah, look, they're probably weak. I could do better than that. Both of those are a little bit cliche. So again, I hope there aren't that many writers listening because I can be more creative than that. I'll work on that. But yeah, look, I think I am often working at a quiet, harder pace than what some people might realize. I also have, I think it's fair to say, have been underestimated at a lot of points in my career. Yeah, so without going into detail, I would just say as someone that was on a 12-month rolling temporary part-time contract in public health, unfortunately, my contract in public health was not renewed last year, which is why I find myself just working in private now. But that doesn't mean that I can't stop advocating for improvements in our public health system, because, and we'll get on to this when we're talking about the book, because there's a lot in the book about that, but that's where my passion lies as well. But what I will say is overall my experience of the first treatment period for the locally advanced was pretty good. I was aware of my recurrence risk. I knew it was not small. So my husband Liam and I really did live pretty well the last 2 years, ticking off a few high enjoyment activities. I wasn't completely surprised there a couple of weeks ago when we picked up on imaging that we were back in a big way. But in some ways, you know what, Michael, I work better for a deadline anyway. So I actually think I'm going to be more productive now, particularly because I can reprioritize and really focus on the things that matter.
Yeah. And, you and I had a very long conversation earlier, and, without me sort of gushing, it was really inspiring to see. And I said it before, I said it in a joking, bantery kind of way, but the Energizer Bunny bull to the matador energy is really something to witness that you've brought to this. And I think that's a good segue to talk about what is, I think it's fair to say, amongst your myriad other projects is your primary project, as it were. And for those of our listeners / viewers on YouTube, you'll see framing Kerry not once but twice. There you go. Is her book A Little Unwell, which was published, what was it, 5 weeks ago? A little more than that, Kerry.
Oh, it's May.
Yes, and already on its second printing, which is a phenomenal achievement. But tell us, for those hopefully like 3 listeners and viewers who haven't read it, because hopefully everyone else has gone out and got a copy and enjoyed it half as much as I. Josh has already, for technical reasons, had to effectively sign off, I suspect.
You can just tell the audience, like I bowled him over that first part of the conversation, so lie down.
Yeah, look, probably, and he's turned off his camera so we don't see it. But yes, so tell us about the book. It's a huge and very revealing look into the life of a junior doctor and the challenges that faces, and some of the problems that in an ideal world would be fixed.
Yeah. So I started writing this book in 2015 when I was a second-year resident, and what prompted it was I'm holding up a book called The House of God by Samuel Shem. This is very well known to a lot of your readers, I'm sure. It was published in 1978, and it's like the seminal medical fiction book. A lot of our TV medical shows like Scrubs and the rest, they've all taken inspiration from this book. So this was the previous standard and was what's still being recommended to medical students and junior doctors when I was coming through. And it is wildly out of date. Like, you read the blurb on the back of this thing, it's basically a sex comedy. There are no interns that are female. It's horribly ageist and racist. And I keep describing it as a really good historic text for understanding where we have come from. But my concern was that medical students and junior doctors reading this would not be able to discern what is out of fashion now or what we have moved on from and improved compared to, there are some good pearls still in there. So I do think it still should be read, but not first. So I wanted to write the book I wish I could have read as a medical student. And
you go through a lot of the trials and tribulations of a junior doctor, I think, really well. And that balance, I think, which, I think it's gotten a lot of comparisons to Adam Kay's book, This Is Going to Hurt, but there is that real balance which is confronting at times of the personal and the professional. And, people particularly who are not in the know often like to think of doctors as egalitarian, empathetic robots that come and are not impacted by what they see and don't carry it home with them. And we know that it is definitely not the case.
Yeah, look, it's a very human story, and I guess what I'm trying to do in some ways is humanize doctors. It took me all of this time to write this book. I had 2/3 of it written when I entered it into what's called the Richell Prize, offered by Hachette for emerging writers. So that's someone that's never published a book before, because prior to that point, I didn't know if my writing was much good. I had an inkling, but I wanted to see if the project had legs. So I submitted it into this competition, and out of 800 entries, it was longlisted in the top 20, which is great. But then I had a wonderful call from my now publisher at Hachette, Vanessa, in late 2020 to let me know that it had been shortlisted in the top 5, which gave me a first look at giving the completed manuscript to Hachette when I was done. So that was just absolutely changed my life in terms of now being a published author. It wouldn't have happened like that if not for that really wonderful opportunity. So just the biggest of thanks and shout out. But then it's not quick to get a book out. So it took me another 2 years to finish off the last third of the manuscript. And then it had to go through all of the review and acceptance and editing process. I was really lucky to be joined at the end of 2024 by my now literary agent, Tom, from A4 Literary. And part of the reason it was the most wild email I sent him, which was basically like, yo, I've got this book and I think it could be really good and we're going to try to get it published at Hachette, but also I've just been diagnosed with cancer and I can't do it alone. Please help. And he was like, okay. And that's kind of the tenor of how our relationship has been maintained. He's always down to clown with me, and I really appreciate that. But the advantage of taking so long to finish off this book means that I wrote a lot of the scenes that involve the bread and butter day-to-day jobs of a junior doctor while I was one, so they are accurate. And I think that's something that's sometimes missing from some medical fiction. We know shows like are doing it better now because they have doctor writers on their writing staff. But I knew if I was going to attract medical readers that it had to be accurate, because the last thing you want me doing is depicting successful CPR on a 100-plus-year-old patient with no ramifications. So there's the medical side of things, but it was also being truthful about what the experience of being a junior doctor is like. Now, I've tried to be balanced. I am not trying to throw any one particular profession that we might meet in the hospital under the bus, but it has to be accurate. So things like nurse on doctor bullying had to be depicted. Things like admin staff, harassment of doctors had to be depicted. And while I have been lucky in my career to have wonderful relationships with both of those groups of people in the hospital, there have been some tense moments as well. And I've had plenty of stories from my peers to amalgamate in as well. And I guess this is over the time period that I've been writing it, and with the wisdom that comes with spending longer in practice and becoming a consultant and having new perspectives, I've been able to continually layer that in on top of this story. So it is now a really rich, robust account of what happens in the hospitals. And I hope that it can do some good. I've had a lot of early feedback from non-medical readers already saying that, wow, we did not know that this is what it's actually like. I think the nurses and midwives are really, really good at advocating for themselves, and I think have a natural sympathy from the community. And that's great. They deserve to be paid well and looked after and have good conditions, because it doesn't matter where you work in a hospital. If you are being well looked after, that translates to better patient care, and that's what I most care about. But I think the weak link at the moment is this unfortunate thing that has been creeping in every year, basically. I think it's getting worse, that it seems suddenly okay to hate on doctors and to make them the scapegoat for all manner of sins in the public health system. And I think we can see that at the moment with the way we look at EBA negotiations in Victoria, and, you know, the class actions that are happening around wage theft. And I get the feeling that there's pockets of the community that truly believe that all doctors, including our most junior peers, are getting around in sports cars and just living the life and working very minimally and just making bank off the public system. So maybe that's a bit extreme. I'm sure that there are plenty of people that know the truth. But when it came to this book, and I'm holding it up now, and on the cover you can see our poor junior doctor Amy, who is the protagonist of this story. And I've got to say, she's not me. This is not a memoir. I've written this place from a place of deep experience, but these are all fictional characters. And I had to do that because my life's not that interesting. And I had to have the cover of fiction to tell the truth. So on the front cover here, Amy is head down on the desk, hasn't washed her hair in days, stethoscope is askew, and she is currently pouring coffee not into a cup, straight into a desk. And again, I've had a lot of great feedback. I had nothing to do with this. This is the lovely team at Christabel Designs did this cover, but they got it immediately. And I've had a lot of early good feedback to say, yeah, we saw that and we got it. So that's what's drawing people in too. So yeah, I think what I can do from here, in terms of my own illness, as we know, the diagnosis I've got is serious, and it's going to be totally dependent how I respond to palliative treatment from here in terms of what runway I have. But right now I feel the best I have in 2 years, which is really annoying. Like, I'm too busy for a terminal diagnosis right now. I've got too much to do. But what I want to do is keep talking about the book, get it into the hands of readers who I know will love it, and use that as a bit of a springboard too to start talking more publicly about what is happening in the junior doctor space particularly. And it's that idea that we need to care for our junior doctors better so that they can care for our patients and for the community. And I just, they have to have hope for the future. And that's why I'm glad you brought up Adam Kay's book. I deliberately did not read that until after I'd finished writing this because I didn't want to subconsciously take in what he'd written. But I came away from that feeling very pessimistic, and I can understand why he no longer works in medicine. But the truth is, I love my job. I love medicine. There are lots of parts of my junior doctor career that I did not love, and I would be lying if I said I didn't think about quitting. There was one dark moment during the COVID lockdown where I put in a job application for Mimco to be a retail assistant because I was like, you know what? I just need some breathing space. Fortunately, they did not call me back for that job. I feel like maybe they thought the medical degree was a little bit excessive in terms of that position. But
they don't know what they're missing, Kerry.
Well, my background in high school, I worked at Coles supermarkets as a facer. That's bringing the product forward, putting the labels at the front. And I did include that because that is past experience that could have been directly relevant to that retail job. But yes, no, they didn't give me a call back, and I'm very grateful because I got myself together and I finished my BPT exams and I got into Nuke Med. And yeah, I love my job. And I just have this feeling that there are so many junior doctors out there now who just can't see the light. We know that there's been a large increase in the number of medical students coming through, but the training pipeline is not reflected with those training places at the end. That's part of the reason probably why I don't have an appointment in public health right now, because we just aren't seeing that FTE for consultants coming through. And this is all stuff that I probably would have been a bit reticent to talk about when I wasn't dying, because I didn't want to lose opportunities for the future. I didn't want anyone, holding me back from future career opportunities because I thought that I was saying too many of the quiet parts out loud. But hey, I have this deadline now. And so if the thing that I can do for everyone out there in medicine who can't say these things, I'll say them to a point. I don't want to go on anyone's hit lists per se. Well, maybe I should just throw it out there. If I do end up assassinated in the next couple of weeks, you'll know why.
We'll know exactly why.
But yeah, look, I have already started. I had an article in The Australian earlier in May. It's available online if you want to have a look up at that. And really the theme of that article was talking about weak leadership in healthcare. And the place that came from is knowing that there are a lot of people being paid very well at the executive level in hospitals, in government, and it's not even about pay. Like, people are taking on these positions of power and influence and then not doing the things that need to be done because it's hard, and it is hard. But I think if you take on those leadership positions, you have to do the hard thing. You are going to feel personally uncomfortable. It is going to be tough trying to balance the needs of everyone. But I guess this is my job now. If I didn't have this terminal diagnosis, would I have ended up as Prime Minister? Maybe. We can speculate on that. Might have taken me a few decades to get there. Might have had to have employed some PR assistants to shed this supposed bogan label that were wanting to put me on, Michael. I'm going to keep coming back to this. You don't understand how incensed I am.
I don't know. That might be a winner for you in the political sphere.
Anyway, look, I don't want to get too political because that's not helpful and not really my personality anyway. I think I'm geared around just trying to do the fair thing. Something I say in the acknowledgements of my book is that a lot of my personality is built around the lessons that my mum passed on to me. And her 3 big things were kindness, integrity, and humor. And I feel like that's really what powers me. And it's the integrity that really in medicine is getting to me a bit, that sense of justice. That is what flares my nostrils. So read this book if anything I've said is interesting, see how you feel about it, start discussing it. And yeah, if with the time I've got left, I can do anything I possibly can to improve conditions out there, that's what I'm going to do, because I think the junior doctors that are coming through at the moment have it much harder than what I had. I'm also worried about that training pipeline and what happens when you get to the end of the training and those consultant jobs are not there. And I see you nodding along, Michael, and I know that this is a big problem in medical oncology in particular. Something that I see that is poor is this model that we've adopted of a pyramid. I'm making a pyramid shape with my hands, where we have all this service provision being done by juniors, unaccredited, and then nowhere for them to go. And that is not what the Australian public need to be healthy. We need to be pulling as many people as we can up to be fully qualified. I know that's expensive, but health is not just about expense. And with everything that's going on in the world, I really just want to motivate those in power to do the best for people out there. And it probably is going to cost a little bit of money, but we can also be doing better with the budget that we have. So anyway, I will disembark from the soapbox now.
As with any soapbox that you get on, Kerry, it's very engaging and nuanced. So thank you. I think we always end these interviews with a question, and you've sort of answered it already with the wisdom that your mum has passed on. But and I'm particularly interested actually as to what you would say to this question. And we say, if you could go back in time, pick a formative point in your life, and you could give your previous self any advice at all, any sort of life-changing advice based on your experience, what would you say?
This week I've had to prepare a bit of a biography for myself because last week I put a little bit of a call out for help on some closed doctors' Facebook groups. And the place that came from is knowing that as a debut author in the Australian market, it's really hard to make an impact because no one knows who you are, doesn't know if your writing's any good. So the majority of debut Australian fiction, or in just books in general in Australian literature, sell less than 1,000 copies. And it's not that I'm making any money out of this. It's like a couple bucks per book that would come back for me. And that's if I earn out my advance. So writing and books is not going to sustain me through this period, but it's about having the readership. And if people don't know about this book, they can't engage with it and then they can't talk about it. So I put out this call last week to the Creative Careers in Medicine group and the Doctors Who Write group, and the response from both of those groups was overwhelming, and it's been reshared. And I heard today that there has actually been a noticeable bump in sales because of that support. And I think the thing that was touching more than anything was just all the comments underneath those posts saying that we as a medical community are behind you and we're rooting for you. And that was more special than anything I could have hoped for. And the reason I bring this up is because I've now had to prepare this biography because I'm getting a little bit more attention and people want to know a little bit more about me. And so in summarising my start in life in Wodonga, I lived there right up until moving away for university at age 18. I was summarising everything I did and then looking at what I did afterwards. And I had this little bit of sadness that crept in because I remember what it felt like being a big fish in a small pond moving to Melbourne for medical school. And I think the crippling imposter syndrome that I felt, particularly over those first few years of medical school, was really unhelpful. I feel like at the time I felt like I tricked my way into medicine, that I did not deserve to be there, that I was the first person in my family going to university for a degree. And I felt sad reading that because then I looked at my biography that came after that, and it's true that I did have to sit the BPT exams a couple extra times. I will say, though, that the first time was because of the 2018 computer exam debacle, which I only missed out by less than a handful of points on passing that one, and then unfortunately didn't get through the next one. But I did pass the next year. But then unfortunately, I feel like having some interesting short stations in my first crack at the clinical exam was a little bit unhelpful. But look, I'm not excusing things. I was also in a difficult place because my mum had just died as well, and I was not well prepared for those exams. But the act of having to repeat those BPT exams has really forged a lot of good things in me, and I don't regret any of it now. I am a much stronger clinician for the extra time that I spent in BPT, and I know that I wouldn't have found my way to Nuke Med if I'd had a straight shot run through BPT. I probably would have been very happy in infectious diseases or geriatrics, but I love my career in Nuke Med. So in that sense, I don't regret anything that's happened, but I do wish I could go back to my 18-year-old self and instill in her some more confidence for what was to come. And I think that's the real message that I would like to pass on to anyone who might be still listening at this point. We've probably dropped down from 3 to 1. I've got to say I've been prattling on a lot. But I think we are so hard on ourselves in medicine. And my husband is joking about this constantly with me. And like, it's a meme, isn't it? That if you don't achieve what you want to achieve, you're berating yourself. And then if you do achieve what you want to achieve, it's kind of like, okay, what's next? So this feeds back into this idea of we need to treat doctors better in general, because I just think there are so many downward negative forces that make doctors feel like they're not good enough, or they're imposters, or it's not working. So that is the message of hope that I want to pass backwards. This is something that I diverge in my approach to medical writing with Adam Kay. I found this is going to hurt to be incredibly sad and pessimistic. Again, for the previously stated reasons, I understand. But what I'm offering is hope. We have a great job. There are hard moments. But when we work together and lift one another up, we can achieve great things. And our patients need us. Our patients are never going to not need us. And so whatever we can do to strengthen one another, that's what I'm about. So now that I've got this devil may care attitude and a deadline, and if, no absolute need to remain licensed by the medical board, let's go. I am definitely going to say those quiet parts out loud and help as much as I can, so that all of you that are moving forward can do better for everyone.
Well, Kerry, as long as we have you, I know you'll be a great credit and a great help to anyone who wants help. Thank you so much for coming on and spending this time with me and the now absent Josh, who's probably still lying on the ground.
One last thing, though, because I was going to give you a practical insider cancer patients tip, something that I've not seen written anywhere that has been a real turn up for the books. The first time I had chemotherapy, obviously lost all my hair. Fine, I've got a great skull. I've been told that multiple times, so I'm not worried about that. I've also got a great wig stylist, so shout out to Creative Wigs on Swanson Street in Melbourne, because they did my look for the launch. I did go as Moira Rose from Schitt's Creek, so find me on Instagram, Dr. Kerry Jewell on Instagram if you want to see how that went, because it was hilarious. But lost all my hair, Melbourne winter 2024. You do not appreciate how much work your nostril hair is doing until you don't have it. And in some quite serious conversations, in some quite serious moments, having one lone drip of nasal fluid just come out randomly and land on my shirt or on the floor while I'm making eye contact with someone, very disconcerting. So do ask your patients about what funny body fluids they are experiencing in the absence of hair. Ears as well. Eyebrows, they were doing a lot of heavy lifting as well. Well, you can see they do a lot of heavy lifting for me. Yeah, the absence of hair causes some very bizarre reactions, and your patients probably won't offer them up. But if you are in for some interesting stories, feel free to ask them, because they've seen some things.
I think that patient perspective is always really interesting. And yes, Kerry, I have had a lot of my patients complain mainly about the loss of eyelashes. Yet another part of hair that you don't realize how important it is.
I try to be a good patient, but I'm not always. Like, there was the time that I was vomiting in the hospital car park because I tried to smash 2 litres of water for my PET scan, so that I was well hydrated. That was a problem. There was also the first time I had an inpatient hospital admission for a port insertion, and I know you know this story, but I was trying to be very helpful and I didn't want to bother the busy nurses because they had said let them know if I needed to pass urine, but that's something I thought I could manage myself once I woke up after midnight. I do not recommend not following nursing instructions on hindsight, though, because I did climb out of my hospital bed, did not realise the rails were up, did not realise how high off the ground it was, did not fall. Like, you're always trying to avoid that positive 12-month falls history. You don't want to, red flag yourself as a problem. But I did take myself to the bathroom and then climb back into bed. Good immediate physical rehab, I thought, until this, the morning nursing ward round where they came round and said, actually, we're pretty worried that you're in urinary retention because we didn't hear from you last night. And then I kind of had to fess up. So please always listen to your nurses when you're a patient. They're structured. They want to help you.
Well, on that bit of advice, I think that's as good a place to end as any, Kerry. Once again, that was Kerry Jewell's book, A Little Unwell. Check it out if you're in Australia, and probably if you're anywhere around the world. It is available, so go buy it.
It is available in New Zealand, and I've been told that if we get enough attention for this, if you could indulge me in purchasing a few more copies, then there is a chance that we could get it out to North America and Europe. Very unlikely for a debut and not expected at all, but we'll see.
Or if you're listening from North America or the UK and Europe and you think it's interesting, just, make some noise.
Go talk to the manager, which is Reese Witherspoon or Dua Lipa. They both have very influential book clubs, so let them know. Talk to the manager.
Done. Thanks, Kerry.
Thanks, Michael. And thank you, Josh, wherever you are in cyberspace.
Thank you for listening to this episode of Oncology for the Inquisitive Mind, produced by ADC Productions, with the assistance of education grants from Pfizer, Gilead Pharmaceuticals, and Merck Pharmaceuticals. As always, these companies do not receive early previews or editorial input of any kind. The opinions expressed in this episode are our own, and the facts are, well, the facts. If you liked this episode, please consider subscribing to be among the first to hear our latest forays into the ever-changing world of medical oncology. You can find previous episodes of our show, including coverage of major conferences, interviews with world-renowned experts and much more, at inquisitiveonc.com. If you would like a particular subject covered on the show, drop us a line at inquisitiveonc@gmail.com. And if you happen to be in Australia, stay tuned for details about exciting in-person events we have planned for the near future. Thanks for listening, and we look forward to demystifying oncology again next time.